we've been talking about PCOD from time immemorial, PCOS and postpartum complications. Nobody really wants to, nobody wants to talk about the postpartum complications. Preeclampsia, eclampsia, cardiomyopathy, hypertensive heart disease, thrombotic disease, congestive heart failure, CVA, postpartum depression are all known to be the inadvertent complications or the long-term complications of polycystic ovarian disease. Gauri, tula pude gyache?
You tell me when to.
Next.
So this is Badhai Ho part 2. When the baby delivers, you again say Badhai.
After we're up with trouble, tackling the 4th trimester. All right, next.
So you want me to move?
Okay. Yeah, next. Just go next. So just to start the discussion, we are all delivering patients who are with polycystic ovarian disease. The problem for most of them is conceiving, but once they conceive, you're also looking at delivery. And after that, 80% of them land up with C-sections. Very few of them deliver normally, reasons best known to everybody. Once they go home, all is hunky-dory. They've gone home, whether normal delivery, whether cesarean section. The mothers are after them, ghee ke laddu kha, ye kha, wo kha, rab pio, etc., etc. The end of it all is they don't come back to us for a while. And by the time they come back, they've got some amount of fatty liver. They've got, some of them come back with acute cholecystitis. And the joke in all of this is most often it's, aapne to calcium khilaya. You gave me too much of calcium. That is why I landed up with gallstones. And I have seen a big population of them coming from the vicinity over here in Powai that blames us doctors for it. So that's where when Uday told me, Anita, will you take this up? It's a challenge. And I love challenges. So that's how we are here. And I would like to throw it open to you all is, what would you advise as routine screening for these patients of polycystic ovaries after they have delivered? Gauri, would you want to take that? Routine. Okay, you're on the phone. Sarita, what about you?
So I think that, one thing is that they are with us till delivery and shortly after. So we must emphasize that contact should be kept, and we have to emphasize that this is a long-term complication, and they must, their lifestyle modification, diet, and everything, and they must check their sugars regularly, lipid profiles regularly, and basically be on continued surveillance is the message.
Yes. Well, how often would it be? I mean, would you advise regularly? Every 2 weeks, every 4 weeks? What would you actually tell them to do?
No, you're talking about post-delivery.
Yes,
so
ma'am.
I'm assuming that this is a patient who has insulin resistance, and therefore their insulin resistance has to be evaluated, and we have to at least see them every 6 months or at least every year.
Okay. Now, so we go on to the first case. And if Gauri is around, a 28-year-old female married since last 4 years, case of primary infertility, conceived on ovulation induction with letrozole 5 milligrams from day 2 to day 6, injection HCG done, and she had planned relations, conceived. At first, that's it. At first visit, her BMI calculated was 29. Weight gain in pregnancy was approximately about 18 kilos. She was diagnosed as diabetic and controlled on metformin. I had a terribly difficult vacuum delivery of 3.7 kilo baby. What would you like to advise this patient on discharge as far as her diet is concerned?
Well, yes, actually, the day of discharge, for me, I take the day of discharge as the one which, will carry off all the messages that have to be gone, because we have this tradition of women going to their parents' place and coming back and things like that. So that day is a very important day, and that for them, that those take-home messages really makes a lot of difference, at least in my practice. Well, as far as weight gain is concerned, she has already gained 18 kgs, and yes, she's going to lose some automatically, so she's going to feel happy. But yes, because she's controlled on tablet, it doesn't mean that that she is not going to have a GDM. I mean, it's not that her sugars are going to come down drastically for some while and then they're not going to rise. So she is going to need a proper counseling session as far as the diet is concerned. And the first thing that will go is, like you introduced, that when they go home, there will be laddu juice and all those high calorific kind of diet. So Dr. Shilpa has taken a very nice talk on what has to be included in the diet, and not about the postpartum rather, but I would like to say that yes, they have to know that some amount of galactogogues that are introduced in our Indian diet are important. I mean, we have not really studied our traditional foods, but they are important, but they have to come with no sugar or less sugar or carb free, and they have to come with less ghee, because like you said, they will have these ideas of taking some 1 kg ghee in so many days, etc., etc., etc. So that is one. And since luckily she's had a vaginal delivery, she can go back to exercise early. So it doesn't mean that she has to be on bed rest once she has had a delivery. She can resume her regular activities as far as possible. One thing when I would always tell my patient, the moment you go home, whether it's a normal delivery or a cesarean, you have to have your 30-minute walk, no matter what. So that is something which they have to go. And yes, they will need a repeated sugar or on her profile estimation, like Sarita said, at regular intervals. And the first visit will be generally, I advise is at 4 weeks after delivery. I mean, of course, one post-delivery and one after 4 weeks. That is the time again when they are, just about come out of those nightmares where the baby is not sleeping, etc., etc. If you let me, I will just want to add one more thing here, Anita, is that those galactogogues and insulin sensitizers that have been in our traditional diet, I have not done too much study on this, but yes, there are a lot of papers which talk about fenugreek, they talk about poppy seeds. They are known to alter insulin sensitivity, and they also act on melatonin, sorry. So they are going to act both ways. So we need to see that, they are given in the right proportion and in the right way. So that is something which I would like to, talk to my patient about.
What about the metformin? She was on metformin right up to delivery. Would you like to continue it, or would you like to discontinue it immediately?
If she has been on metformin pre-conception through conception.
No, she was not. She was started at 28 weeks.
Well, I would like to continue the metformin for a while because it is not contraindicated during breastfeeding per se. I will continue that metformin for at least 4 weeks and then reevaluate her.
All right. What about you, Sarita?
Anita, I think, let's be clear what we started the metformin for. If we started it for gestational diabetes,
yes,
then that is a different issue. If we have started it for insulin resistance before pregnancy, yeah, I'll definitely continue.
No, she was diagnosed as a gestational diabetic, which was controlled on tablet metformin.
Okay, so then I think we'll watch the sugar, and then decide about the metformin.
Absolutely. Absolutely. I would totally agree with you. Here, what we do is we have a metabolic clinic and we have a multidisciplinary team approach with a joint consultation of the metabolic physician, the dietitian, exercise consultant, and a clinical psychologist with stringent follow-up with one-to-one telephonic and in-person consultation on daily nutrition and physical activity, weekly weight and measurements in inches for the patients. So we're a little strict about these patients because we have the class of patients that we deal with, we'll end up with more trouble than we would like. Sarita, would you like to add anything on the exercise schedule of this patient since Dr. Hariharan is not around?
She's there.
Oh, she's come.
Thank you. So would Dr. Hariharan would like to talk on the exercise for a patient post-normal delivery when she's getting discharged?
Yes, definitely, ma'am. On the day of discharge, I would like to check about the diastasis rectite. Only then we will be able to decide what amount of exercises she can do. And since she had a large baby by vaginal birth, we also want to see how her pelvic floor muscle contractions are, because that is what is going to decide how safe it is for her to indulge in, more strenuous exercises. So, having evaluated these two things, we will, give her discharge advice on if there is a large diastasis, how to bring it under control, and gentle abdominal exercises, which she can safely follow, pelvic floor exercise, basic back care, which she should follow at the time of discharge, so that during the period of immediate breastfeeding period, she will not get into pelvic joint dysfunctions or backache or things like that. And I will also give her advice on how it is essential to, walk around. So usually what I suggest is to keep the exercises along with the baby routines. After the feed is over, when you have to burp the baby, Don't sit in one place. Just get up, carry the baby, so walk around the house. So this will ensure that there is no stasis of blood and, coagulation, all these problems can be reduced. So this is good enough for the first 2 to 3 weeks. And ideally, we would want them to come at least once before 6 weeks so that, we can fine tune the exercises. So ideally at that time, we would want her to develop the core. So I would not recommend them to go for intense exercises. Usually women are very enthusiastic, especially those who have been exercising with weight loss and all. They want to know when they can hit the gym and when they can do weight training. So we want them at least 4 to 6 weeks of time to develop the core. Mainly the pelvic floor has to pick up strength, the diastasis has to close, the transversus abdominis should work well, and the multifidus of the back should work well so that they can give that stability. From 40 days, I would say you should go out for a walk. You should go for a brisk walk, engaging the core. You can tighten the pelvic floor muscles, engage the deep belly muscles, and go for walk. And slowly you have to increase the level of activity. There is no one prescription which will fit everybody. So everybody is having different levels of fitness. So a good 4 to 6 weeks is a good, training program where they can bring their core muscles to a better function, and then accordingly they will be able to increase their level of activity. So after they have done 4 to 6 weeks of all these activities, then they can engage in much more strenuous exercises, according to how much their muscles will allow them to. So at that time, I would suggest them more about how they have to exercise safely. I would not want them to, be with me and stick to a, exercise within the small walls. I would want them to explore, move outside, pick up any other fitness activity of your choice, so which will give you happiness, which you feel you can continue long term. But
So,
with background.
Thank you so much, Dr. Hariharan. So in conjunction with what you said, that's exactly what the ESHRE guidelines of 2018 also tell you. Advise moderate amount of weight loss, prevention of any weight gain, and 250 minutes of walk or moderate intensity activity per week, 150 minutes of vigorous intensity activities, or an equivalent combination of both, with muscle strengthening activities involving major groups on 2 non-consecutive days. Minimize, obviously, sedentary screen or sitting time, which most of our patients would like to kind of indulge in: televisions, computers, etc. Sarita, going back to you, would you like to talk a little bit on the contraception that you'd like to advise this patient?
Yeah. So for these patients, initially, of course, if they're breastfeeding, that works well. After that, we can't. So the ideal choice in a PCO patient is a combined oral contraceptive pill. However, we can't give that initially when they are breastfeeding and exclusively breastfeeding, because we have to, wait for some time. It may reduce the breast milk. So I think initially they can be, if they are ready for an intrauterine contraceptive device, we can give them that. And then later on, I think combined oral contraceptive is a very good option.
Absolutely. What about you, Gauri? What do you do? Do you use a PPIUD or for any of your patients, especially with PCOD, or would you stick to OCs?
Well, for the initial part, I do stick to the PPIUDs because of the risks versus the benefits. And also, I do suggest for progesterone injections for the first year, because that makes it a little simpler. But only progesterone is something which I generally would prefer, progesterone only pills or the Depo-Progrera injection that we have. And then maybe, because sometimes patients are not very happy to start with an IUD. So, but yes, my second choice would be an IUD.
I would agree with you. So yes, initially itself, that's exactly what the WHO medical eligibility criteria also says, in concordance with us, that in spite of the fact that these patients can have dyslipidemia, in fact, the fact that they can have metabolic syndromes, progesterone only is the initial drug of choice, and then COCs as you go ahead, because the amenorrhea which is associated with progesterone only may not be something that the patients are very much in tune with. So the COCs, after about the first 4 months of breastfeeding, they're good to go on that, because by then you've started introducing some amount of top feed or homemade preparations. Going on to our next case, we talk about a 35-year-old P1L1 post-delivery 1 week. She's a history of PCOS and GDM and was on insulin. Full-term vacuum delivery at 3.6 kilo baby. What would you like to advise this patient regarding control of sugar in the postpartum period, and how would you regularly follow her up? Because you do know that these patients are higher incidence of developing type 2 diabetes mellitus. Gauri?
Well, this patient has already have been on insulin, and of course, as we know, as immediately post-delivery, we will see a good drop in the sugar. So probably when she goes home, she might have normal sugars, but there are a good percentage of patients who do have persistently high sugars even after delivery. So depending upon that, she will be continued on her insulin, depending on what kind of her sugars, what her levels are showing us. And yes, of course, she'll be monitored every 2 weekly for the first 1 month, and then after that, again, depending on her sugar levels, we will be continuing. But the most important thing I would want to say is that here, again, counseling will form a very important role, that you need to follow up regularly, because once the delivery is done, all is happy and hearty, and they tend to forget all these things behind. So they need to know that yes, they need to follow up this very strictly, not only for type 2 diabetes, but for other complications, which we probably would be discussing. But yes, I mean, this is how I would want to follow up this patient, along with dietary modifications, which will continue. And as Dr. Nigamaja said, continue exercise and continue to monitor your sugar levels strictly.
Yeah, so exactly what we would, what literature tells us is the incidence of type 2 diabetes was 2.8 per 100 person years, and higher for those who receive pharmacological treatment for GDM, that is 6.6 versus 1.5 per 100 person years. Blood sugar monitoring in the ward when they are admitted, on discharge, self-monitoring of blood sugars, diet recall, follow-up after 2 weeks with plasma glucose levels, and 6 weeks post-delivery, you would get a fasting, a post-meal, and an HbA1c done. If abnormal, refer the patient to the diabetologist, because by now she is then a type 2 diabetic and will require regular follow-up, be it diet, be it exercise, be it metformin or oral anti-diabetic drugs. Sarita, what's your take on metabolic syndrome, and how many patients do you actually see in your practice today associated with PCOD?
Just 1 minute. Can I just come in for a minute?
Yes, sure.
Yeah, see, one or two things, like firstly, what you are saying about starting contraceptive pills after 4 months or so. These days, pediatricians strictly say only breast milk till
6 feet.
6 months.
Yeah.
Yeah, but after 4 months, you can start the OCs, because by then the lactation
Milk flow is well established.
Is well established. That's exactly what the WHO criteria says.
Okay. Secondly, when you talk about insulin, a patient who's on insulin, is there any ratio, Gauri, by which they reduce the insulin dose? Is it 1/3,
50%. I think after delivery, they say it comes down by 50%.
50%. That's what I
Yeah.
thought.
Absolutely.
So you can start with that, and the more. And are you going to talk about recall of these patients? Because
Yeah.
I'll tell you, I advise PP, IUCD. I advise IUCD, but yeah, normal patients also come back after 1.5 months or 2 months or even 3 months and put in a IUCD. Nobody comes back. They come back when they conceive after 8-9 months. Abhi to pregnancy ho gayi. हमने तो सोचा नहीं था हमको इतना जल्दी हो जाएगा. So how do you recall these patients? These patients are diabetics. They've had abnormal sugar, but with a baby at home, with all the housework or whatever, they don't even think of contraception. They don't even come back for contraception. Forget sugar monitoring. So what do
I
we
guess
do?
we're all dealing with different class of people, because when
Yeah,
you
that's why I
advise,
want inputs from everybody how they do it in their practice.
yeah,
Anita, for you also, let's start with you. How do you manage it in
so
practice?
if I tell you honestly, like I told you in previous while I was discussing, when the patient is in the ward, her sugars are monitored, a post meal and a fasting. Now, if she is still high, then obviously the insulin levels are decreased, the dose is decreased, but she's back on insulin, and we continue it. The diabetologist comes and sees them 48 hours post birth, irrespective of the mode of delivery, and advises whether you need to continue insulin or you can shift back to oral anti-diabetics. Once they go home, they have all been advised to do a self-monitoring of their blood sugar, which is a fasting and a post meal. It could be either one meal. So they do only 2 readings per day, and they come back with a chart after 2 weeks with their glucose levels. If they've been given a range of 95 to 100 for fasting, and post meal of 110 to 120. If their ranges go off this, they have to come back with their diet recall, which all of them, there is a chart which is made, and they have to just fill in their charts. Now they come to me 1 week after delivery, 2 weeks after delivery, and 6 weeks after delivery. 6 weeks after delivery, I advise a fasting, PP and HbA1c, and depending on that, then they go further with the diabetologist. That's what I do.
So this is ideal. The only thing
No, this is
for that-
compulsory in my OPD, because I run the high-risk
No.
pregnancy unit.
Yeah.
So these are
well,
all...
Uday,
That's what's supposed to be done. That's technically what's supposed to be done.
okay.
Let's talk about the GDM patient. Abhi usko chutti ho gaya. In the ward only her sugar is in 3-4 days only her PP is coming to normal, and you're doing a monitoring, and now she's going home. It's very difficult to get these patients back. And another thing which I wanted to point out is that instead of doing a fasting and a PP, you also at 6 weeks should do an OGTT now, because that is the recommendation, doing an oral glucose challenge test for at 6 weeks, 6 months, and once every year for any woman who is diagnosed as GDM. That is all taken, but the idea is, how do you call back now? Now one of the ideas which was given by Dr. Anil in the IDA was that let's mark the vaccination card of these women. The pediatrician should mark that this child is a child of a GDM mother, and that pediatrician should say, okay, now you've come to me with your child for vaccination. Have you gone back to the obstetrician and or have you been monitoring your sugars, or have you kind of contacted your obstetrician back again? So that is one way to keep a watch on these, because this the whole chunk of diabetic women who are there. We can keep a watch on them. If we know that they're GDM, we've picked it up, we manage the GDM. Even if she's on diet and exercise, we manage the GDM. But this girl is also at risk of developing diabetes, so she should be made aware of that. What I do in my practice is, and we all as obstetricians can do, is at every antenatal visit from the 7th month onward, we have to drill it into their heads that after delivery you can't lose track of your sugar. Whatever you are doing now in pregnancy, in the 7th, 8th month of diet and exercise and monitoring your sugar, after delivery, please continue that. Don't switch back. Monitor your sugars at 6 weeks, at 6 months, at 1 year. And because you are at the risk of becoming a diabetic, and that until they are told several times, it doesn't go. So I do it at every antenatal visit after the 7th month, and tell these patients that you have to come for a follow-up, have to come back. In spite of that, the follow-up rate is very poor. So Gauri, in your practice, or Sarita, in your practice, if you have any other methods of calling these patients back, please do share them.
Okay, yeah, Uday, see, what you said is right. See, when they're coming to you for antenatal checkup, that is the best time to sensitize them. Okay, because that is the time when they are so receptive to whatever you say. So you have to, like you said, you are going to counsel them all through about GDM and its short-term effects, long-term effects, whether it's going to stay or not. Because this is one very common question that women are going to ask: "Ye mera diabetes rahega kya?" So this is something which you have to tell them, that only monitoring will be able to tell you what is going to happen happen, and don't give any false assurance that once you deliver, you're going to go off everything. So you have to give them the actual possibilities right in front of them. Secondly is that once they have gone home, what I generally tell them is that every weekly they are supposed to call up the hospital and they are supposed to give us a reading of what they have done. Okay, so we have a number of calls coming in, but still we do ask them to give me a feedback every 1 week. They are supposed to come back and tell me what their fasting and post lunch sugar is. And the next thing is to call them back at 6 weeks. I tell them, before you meet your husband, you meet me. So that is something, because it is no guarantee that breastfeeding will give you 100% contraception. So there is nothing. There are women who will come pregnant even if they have not had a single period. So when I have put this into both of them, that before you have your first intercourse, you have to see me, then you see each other. So that probably might be helping. I don't know, it's not 100%, but yes, to some extent it does work in the clinic.
That's brilliant, Gauri. What about you, Sarita?
Well, I think that it is difficult, and I think that they are not very receptive when they have a small baby at home. They're just not receptive, but over a period of time, they've built confidence in us. And I tell them to come back, and maybe they won't come at 3 months, they'll come at 6 months, or they'll come at 1 year. But whenever they come, we take that opportunity.
Perfect. Do you want to go on to the next case?
Yeah, I think you were asking me about
metabolic syndrome.
Metabolic
syndrome. Yeah.
So yes, I see a lot of many patients now who start off with PCOD, gestational diabetes, and metabolic syndrome later. And this is just the whole continuum of the spectrum. And
absolutely.
So I completely agree with you that this is, and they are with us for a fairly long period of time. We have to just emphasize what you've put up: diet, exercise, lifestyle modification. And I really believe that metformin is a wonderful option for insulin resistance.
I totally agree with you. I can swear and say that. So we'll go to the next case now. Gauri, yeah, that's a 42-year-old IVF.
Which women will you put on metformin?
So Dr. Uday, I think basically, if I feel they have insulin resistance, either clinically or, by their fasting insulin level, then I put them on metformin. And I think metformin, even in, 500 milligram twice a day, say 1 gram or 1.5 grams, does help to control the insulin resistance, to control the weight.
So it'll be basically for women who have got an abnormal sugar, right?
No, not only with abnormal sugar.
If they're pre-diabetic, they may be pre-diabetic, or they may have a high fasting insulin, or they have an insulin to blood sugar ratio which is less than 4.
Yes, so and the HbA1c is between 5.7 and 5.4.
5, yeah. So that's pre-diabetic. Or if they're even if they are
acanthosis.
They're acanthosis.
Acanthosis very commonly.
So clinical or biochemical.
Yeah, and they need not be always coming to you only for a postpartum visit. It could be for any condition or any other problems also. It is like you have to really probe into, or just expand your consultation a little more, a little extra to talk to them about this issue. And you do have history from patients talking to, and patients with PCOS already have read so much about Google, and they're all the time looking at PCOS on the net. So that is one thing, that they're already quite aware that they are facing some problems. Secondly is that when they're overweight, they're coming to you for any issue, any gynec issue also. You can just expand your consultation a little extra and talk to them about metabolic syndrome and possibilities, and GDM and dyslipidemia, and how it's going to affect their lifestyle, their life not only today, but once they are post 40, post 50, post 60, what's going to happen later. So just check it today. So that is something which you must extend your consultation a little extra and support them.
Yeah, talking of the net, PCOS Society keeps on, Conquer PCOS keeps on putting things on Instagram, and there's a lot of awareness has been created, and a lot of things have been created about PCOS.
Yeah, Uday, but with most of these women, the looks themselves, it kind of matters to them. So by the time they're done with 6 months breastfeeding, etc., now they are worried because the blackening, doctor, why won't this fade? They do make their appearance in your OPD. So if you have, because we have a metabolic clinic, we have all these people, like I explained to you. We have a complete follow-up of these patients. You have people calling them up, come back, and getting after them. But that's the only thing that will prevent your Gen Next from having issues.
Yeah, but like I said, Anita, I mean, in my hospital, we won't have a metabolic clinic, but then, you know, your eyes are open, you're listening to the patient, and yeah, I mean, she is obviously sitting in front of you where she is having the symptoms of pursuit, which are missing nowadays because of the masks. But then still, I mean, yeah,
I agree. There is
you just asked her to lower it and just ask her for, you know, let me see, I want to see whether you're pale, and, you know, look for that hirsutism quickly, and, you know, just touch on that. So that is something which you're missing because of the mask, but then still, I mean, we can still do a good job.
I'm 100% agree with you on this. Absolutely no disagreement. Gynecologists, because the very fact that we are with them for 9 months and more, they are definitely closer to us than the other consultants. So they don't look at us with tinted glasses. But having said that, let's go to the next case, which is a 42-year-old.
One small input here, that there are almost 413 people watching this panel. So great going. Congratulations.
Thank you, Uday. Thank you so much. The credit you should be taking. But this 42-year-old IVF conception, obese, BMI of more than 31, history of PCOS, conceived, GDM controlled on insulin, large fordate fetus, polyhydramnios, also had gestational hypertension. So I took her up for an elective LSES at 38.6 weeks, baby of 3.9 kilo. She had an awful experience with breastfeeding. It was becoming very, very difficult. And the next visit, when she came to my OPD, she was a bag of nerves. She was weeping. She says, I feel suicidal. She was crazy. So what, in your opinion, is the prevalence and severity of depressive and anxiety symptoms? And do you think that all PCOS should be screened? Do you think that these patients are more prone to develop depression? And what would be your ideal treatment modality? Gauri.
Okay. Well, it is well established now that there are a lot of psychological disturbances and psychiatric illnesses, especially depression, which is associated with PCOS, irrespective of whether they are pregnant or not. And there are a lot of studies which have come. In fact, just one of our last webinar was on depression and psychological symptoms. PCOS Society itself had held it, which brought out such an important thing that yes, there are a lot of disturbances, depression, anxiety, which already goes with the pathophysiology of PCOS itself. It is not only a result of the cosmesis or the irregular periods, it is inherent within the metabolic pathology of the disease. So we must already have a look out for this before they conceive. But yes, after they conceive or after they have delivered, with all these things, with lack of sleep, have baby to handle, and all these things together, and also postpartum blues are known for all our patients. So when you have this, when you have a PCOS patient, you have to be more watchful for these symptoms and for these whatever complaints that the patient is giving you. And yes, I mean, we need to have much more vigilance on postpartum depression and psychosis in these patients, especially because they're already prone to this because of the pathology that they have.
Sarita, do you find an increase in your population, your patient load too?
I think one thing is older mothers. Second thing is nuclear families, very little help. And, you know, looking after a small baby is quite a challenge. So I think that definitely postpartum, you know, depression is on the rise, and one has to be really very sensitive to these problems. And, you know, they need help.
Yes, and a multidisciplinary team of a gynecologist, a dietitian, a health psychologist, and a psychiatrist, if at all required, or a lactation consultant to kind of prod them along and push them along to encourage breastfeeding. And you may occasionally even have to put them on Sarita or any similar anti-anxiety drugs to kind of tide through the crisis. PCOS patients are also known to have multiple pregnancies, preterm births, PPROMs, which may further exaggerate any existing psychological issue and increase the incidence of postpartum depression, hence requiring medication. ESHRE guidelines also say the same thing. So we have to be extremely vigilant and keep a watch on these patients before you have trouble brewing. Going on to our last case now, We have a 33-year-old with history of PCOS, morbidly obese, known case of hypercholesterolemia, fatty liver with cholestasis of pregnancy at 28 weeks gestation, cesarean done in view of premature rupture of membranes at 35 weeks with unripe cervix. At delivery, SGOT 232, SGPT 238, ALK-Phos 468. Patient was discharged on UD-Liv 300 milligram 3 times a day. Surgery was uneventful. Everything was fine. But how would you follow up this patient?
So I think here again, we need a multidisciplinary team, and we need a liver specialist here involved. And if it's just cholestasis of pregnancy, it's likely to, come back to normal. But if there's a primary liver issue, then it needs to be managed by the, the hepatologists. So that's what we would do in our setup.
Agreed. Dr. Hariharan, would you like to add anything as far as non-alcoholic steatohepatitis or NAFLD? Would there be anything as far as your exercise schedules for these patients? Push them a little earlier. They are morbidly obese.
I have not come across patients with liver cirrhosis or something who comes for exercise prescription. So I would not really.
Gauri, what about you there?
Well, I mean, you've been really happy and lucky that you've come uneventful with this delivery, with the liver enzymes raised and all these problems. So first of all, because the problems begin there itself when you're delivering a patient with all these raised liver enzymes and a fatty liver already. So good. Congratulations to your setup and your team for doing this. Now, moving on to what we have actually, the point that we are trying to draw in is that non-alcoholic fatty liver disease is again very common in PCOS, and there are a lot of recent studies coming in whether patients are obese or non-obese. It really doesn't matter, but
absolutely,
yes, non-alcoholic fatty liver disease is again inherent because of the inflammatory responses that the central fat or the visceral fat is going to raise. So it's very important when we have a patient who comes to you with any routine ultrasound or even in pregnancy, and you will see a report saying fatty liver of pregnancy. Okay, now that fatty liver grade 1, and generally, what I mean, I would generally some months ago would just overlook fatty liver, but it's not that easy, and it's not that simple, because it is an indicator, or it's like a green signal ticking and telling me this is a problem and this is going to cause a liver disease. Now, unfortunately, ultrasound does not really completely differentiate between hepatitis and just non-alcoholic fatty liver disease, but these women need to be monitored regularly as far as their liver enzymes go. And there is Dr. Nigamaja's role where they have to really, even if they are lean or they are obese, they must exercise and they must go ahead with loss of visceral fat. Their target is loss of visceral fat, and there are a lot of things which are recommended, and metformin, yes, it's known to really play a good role in this. So again, we have metabolic syndrome, or this, metformin is the today's
drug of choice.
Yeah,
it is the manna for all the insulin resistant people like me, but yes, it works like magic. And NAFLD is definitely associated with insulin resistance. It is 44% versus 20.8% in controls. So 44% of PCOS there's 25% increased risk of cirrhosis over 10 years in these women. It's all about lifestyle modification, and a 6 weeks post-delivery ultrasound for the liver and the gallbladder is mandatory for these patients, with an LFT, with possible referral to the hepatologist if any of this comes abnormal. Metformin definitely helps because it helps you mobilize the fat. In these patients, do you think that there is, in these morbidly obese patients, any role of LMWH postpartum?
Yeah, we do give low molecular weight heparin, especially it's if we're to prevent the risk of thromboprophylaxis.
Absolutely. So in all of these patients, if the BMI is between 30 to 39, it is 40 milligram once daily. And if the BMI is more than 40, then it would be 40 milligram every 12 hourly. You will continue DVT prophylaxis. You will get the patient's early mobilization, and you will not need to continue it once the patient is completely mobile. And you would definitely tell them immediate post-op to use the stockings and the DVT pump so that you prevent DVT in these patients. I think that would bring us, what about long-term follow-up of these patients of metabolic syndrome? Would you like to call them back every year, or these patients of PCOD? So what?
Yes, I think definitely.
Absolutely.
I think we once a year, and their their lipid profile, their diabetes check. We have to watch the liver function, even a sonography for the fatty liver, all these things, and we have to keep.
And the closer they get to post 40, you would also ask for an ultrasonography for the endometrial thickness, liver function test, OGTT, HbA1c, lipid profile, and the BMI to be calculated every year, so that they are constantly aware of the risk that they live with just because of the fact that they are PCOS. Thank you so much, all of you. I think you'll have answered all our questions, and I hope
Can I make a comment? Can I make a comment?
Yes, ma'am.
Oh, no. Well, I just wanted to make a comment regarding that. Okay, we have managed this woman. She's come to us with postpartum, whatever complications and PCOS and GDM, etc. One thing that we really need to talk to her about is that if your offspring has been large for gestation and you had GDM in your pregnancy, your child, when it enters into adolescence and goes into the adult stage, they are at high risk of developing the same. So they have to be very careful and very vigilant on their children as well, as far as their weight gain is concerned, as far as their nutrition is concerned, as far as their exercise habits are concerned. Because like we talked about that, we are not like there was a slide which talked about that that woman is not carrying only one child, she's carrying the grandchild as well. So that is very important, that this is a Gen X and we are facing it's like a pandemic now. PCOS is getting like a pandemic, and we need to hold on somewhere. And that is where, these women have to be told how their children have to be, their diet and their exercise, how it has to be from the day, right from the beginning. So that is something which they are very receptive to when they come for our postpartum visit, and we must talk to them about that as well.
I would totally agree with you. It was just a little off the topic, so that is why I didn't add. But if you actually go through the literature, there is a lot of papers where direct association of nearly 60% of the babies born to PCOS mothers who develop metabolic syndrome after adolescence.
Correct.
One more input, Anita, is about when you talk about depression and all that. It's not in PCOS patients. Even the ASHRAE guidelines say even when they are eating in gynac, we need to diagnose what is.
Yes. Oh,
so
yes.
What I have found a little easy is to make them fill a WHO well-being index. Now, every infertility one will give you a list of questions which you can ask the patients to see how they are doing mentally, whether they're mentally depressed, anxious, etc., and what degree. So I have found this is only 5 questions, 5 answers. You tick mark and you calculate a score. So this WHO well-being index is something which is available on the net. It is very simple, because the patients don't talk so much, that at least infertility patients, either the mother-in-law is talking or the husband is talking, the patient is poor thing sitting quiet, and you don't know what is the mental status. I found it very easy to make all the patients fill up this well-being chart, and you come to know how stressed they are. So it's a good tool to diagnose stress, because stress is not easy to diagnose.
And today, with the pandemic and lifestyle change, totally, there is a lot of stress in the general population. And all the women are the ones who are taking the brunt of it.
Here, can I add one more piece of this thing?
Sure.
Because women who usually exercise in the pregnancy period, so they are less likely to get into, too much of stress, or when they are into a stressful situation, it can reach the doctor easily, because as a therapist I give much more time. Lady spends nearly 1 hour 3 times in a week, so many a times they talk about other things, in the exercise class. So many a times it comes to me that the mother is probably depressed, she needs help. Then I talk to the doctor and ask the mother to go and reach out to the doctor. So this way, exercise has a protective effect, and when they are going to a person who is non-judgmental, who is not a family member, they tend to open up. So that helps, and with lot of support,
The
getting
endorphins which are released post exercise always give
Exactly.
you a great feel, like you've got
Definitely.
everything under control.
Yes, yes, definitely. And they need
It's
a
a
very
good feel.
supportive family. And they need a supportive family, somebody who can listen to them, to whom they can talk to. There are many times women simply, they come to me, they say that I want to come for exercise. It has so happened that they just want to talk. One entire hour they will talk. They will not want to learn any exercise. The only thing they want is somebody who will, listen to them. So
So it's brilliant. All in all, it's a good way for a patient to let out. I mean, why patient? Even I do it. And I think being able to go and exercise in gym really makes you feel good.
definitely, definitely.
Yeah, but in COVID times, don't go to the gym. Anyway,
I'm going.
you are young, we are old.
Oh, go on. I'm done with COVID. So I still have a few antibodies left. So I'm going.
You're lucky you're done with COVID and you're protected. So anyway, but it has been a great interaction, I think.
Don't
Anita.
announce.
Uday, there's a question, but which is not related to PCOS. So Dr. Bhavya is asking, kindly answer if time permits. Do you advise all patients about HPV vaccination in the postpartum period?
Anita.
Me? I'm the moderator. You. I don't. I honestly don't. I do not. My target population with the HPV vaccine is more the younger population. Children above the age of 12 years, young girls is where I give it to them. And the older population, most of them are already vaccinated. And for those who are very keen on it, yes, I don't discourage them. But primarily, post delivery, if you're going to ask me whether I promote the HPV vaccine, I'll be honest with you, I don't.
Yeah. What about Gauri and Sarita?
Well, I think that, one can sort of
I
discuss.
was offline for a while.
Discuss in the, maybe not immediately postpartum, and they come for the first postpartum visit and they say, so doctor, when do we see you again? Or, what do we have to do now? Where do we go from here? So one of the talking points could be definitely the HPV vaccine.
But I think the younger the girls you give it, the better. So I don't
The
know.
better. That's
Yeah,
exactly what data
of
says.
course, the protection is better, but there is still protection even if you give it later.